this, I would like to invite Dr. Ali Asghar. He's Assistant Professor and Consultant Endocrinologist at Liaquat National Hospital and Medical College. He's also the Vice President, Pakistan Endocrine Society, and he will be talking about combining glucocentric and cardiocentric approach in management of type 2 diabetes. Dr. Ali, please join us.
Bismillahirrahmanirrahim. Thank you very much, Pakistan Society of Internal Medicine, for inviting me. I hate these stages to stand up there, so I'll just come down and try and be close to all of you. So, my topic today is combining glucocentric and cardiocentric approach in type 2 diabetes. So, with the permission of the chairs, I would like to start. So, I see quite young physicians up there, so I'll be coming close to you as well. So, be on guard, be awake as we talk. Thank you. So technology has its own problems. So why do we treat diabetes? So I'm an endocrinologist. I am somebody who treats diabetes. So anybody from there, why do we treat diabetes? Why I am interested to control fasting plasma glucose, random plasma glucose and HbA1c? Why? Just to treat the numbers? What is the goal when I am treating the numbers? To avoid complications. That's the biggest thing, that we need to avoid complications. So, if you see, people with diabetes are 3 times more likely to die of heart disease. People with diabetes are more likely to develop heart disease at a younger age. And as an endocrinologist, as somebody who treats diabetes, I would like my patients to get prevented from this heart disease at a younger age and also at a later age. Now, up to 80% of people with diabetes will die as a result of a heart attack or a stroke. This means that if I see 100 patients with diabetes, 80 will die from heart attack or stroke. So my responsibility is not only to treat the numbers, but actually to translate these numbers into preventing these heart attacks and strokes. And that is where the modern concept comes in. Not only the glucocentric, but also the cardiocentric approach in managing diabetes. So what do you think? Controlling HbA1c is important? Yes or no? Come on, you're awake? Yes, it is. Glycemic control should be the top priority in diabetes to prevent complications. So whatever we do, we have to control fasting plasma glucose, random plasma glucose in HbA1c. That is the crux of diabetes management. Now just see this, stroke and acute myocardial infarction. I'm sorry, I can't just point it there. So you see stroke and acute myocardial infarction and the factors which are important in causing stroke and heart attacks. Now just see myocardial infarction, top of the list is glycated hemoglobin. Next is systolic blood pressure, LDL cholesterol, physical inactivity, smoking, marital status. So don't smile, you cannot change marital status. You can change a lot of things up there that you see. So HbA1c is very important. Bad HbA1c is something that will lead to stroke and heart attacks. So as somebody who manages diabetes, you have to control HbA1c fantastically. We talk about many fancy things, really. We are into new medications, we talk about fancy things, but what are we doing for diabetes itself? So this is what is happening globally. Uncontrolled diabetes, 69% in diabetics in Pakistan have an HbA1c that is more than 7%. So we talk about a lot of things, but the base thing that is there, controlling diabetes, we have not yet mastered this basic thing in managing diabetes. So as the world is talking about more glucocentric and cardiocentric approach, probably in many parts of the world and in this part also, we are yet to actually attain glucocentric approach also in the management of diabetes. Now we all know 1% reduction in HbA1c reduces myocardial infarction by 14%, microvascular complication by 37%. So when I am treating diabetes, I am not only looking at the numbers, no. I know that the numbers that I am treating will prevent my patient from going to a wheelchair or a stretcher, and that is why I practice. That is why I tell them that you are taking medication and listening to me. Now, UKPDS. So, okay, we all agree we have to control diabetes. I mean, full stop. Early diabetes is very important. Somebody who comes to you at 30, 35 years of age, he's pretty young, he doesn't have symptoms, he doesn't want to control diabetes. मरीज तो कहता है मुझे कुछ होता ही नहीं, मैं जब होगा जब देखा जाएगा. But this is a national culture that is there. As a good physician, we need to tell our patients, look, the early tight control of diabetes will give you a life which can be free of complications or with less complications. Look at the UKPDS. When it finished, then there were two arms, conventional and intensive glucose control. Even after 10 years when the study finished, even after 10 years, the intensive arm had less microvascular and macrovascular complications. And this is known as the legacy effect of the metabolic memory. बच्चों को होता है ना, छोटी उम्र में आपने बच्चों की अच्छी तरबियत कर दी, अब वो सारी जिंदगी चलते रहेंगे. Same goes with diabetes. So it's very important that young diabetics should be explained that you need to control diabetes well in the early part of your diabetes. All these studies, I mean, all these landmark trials, we see that the events, the non-fatal myocardial infarction were less when diabetes was controlled intensively. This means that whatever fancy things we think about, controlling diabetes is at the heart of management of diabetes. Simple as that. And as I talk about glucocentric, I'll move towards the cardiocentric approach pretty soon. So these are the deaths from cardiovascular disease from 1999 to 2013, and we see that cardiovascular deaths are coming down. Kudos and congratulations to our cardiologists sitting here. They've been working hard to bring down the cardiovascular disease. But still there is a gap between cardiovascular disease and diabetics and non-diabetics. And what we can do as somebody who is diabetes specialist, and there is so much diabetes in Pakistan that everybody has to be a diabetes specialist, whether be a cardiologist or a gynecologist or an orthopedic surgeon, everybody has to manage. There are 3 crore diabetics in Pakistan. I mean, 125 endocrinologists and probably thousands of diabetologists alone cannot do it. So again, what can we do to bridge this gap and reduce the cardiovascular morbidity and mortality in diabetics? Probably we can't do that, but we can actually think and do something at least. Look at this, heart failure is also more in diabetics. Then heart failure with type 2 diabetes has less survival than heart failure without type 2 diabetes. Another challenge for the cardiologist as well, and the endocrinologist and diabetologist as well. So it was decided that whatever diabetes medication will come in, it has to have a cardiovascular outcome trial. I mean, come on, I treat diabetes, but that can increase heart disease, so मैंने treat ही क्या किया? I mean, 80% of my patients will die from heart attack and stroke. If I control HbA1c and my patient still gets a heart attack or a stroke, I mean, what have I treated then? He can still have it, but I can think, how can I go down in reducing heart attacks and strokes? So again, the modern day management is now changing. You know, what is the gold standard approach in diabetes? How do you start in diabetes? Yes, come on. I have limited time, I'll try to finish on that. Lifestyle, fantastic. In busy clinics, many a times you don't talk about lifestyle. Well, lifestyle has a major role to play, diet and exercise and no smoking, and there's marital status as well, but I don't go into that discussion, my time is only 15 minutes. So metformin is the first line medical treatment then, and the 2 emerging therapies are SGLT2 inhibitors and GLP-1 analog. Before I move forward from here, GLP-1 analogs are injectables and 10 times more expensive than SGLT2 inhibitors. SGLT2 inhibitors का महीने का खर्चा है 1,500, GLP-1 analog का महीने का खर्चा है 15,000. पाकिस्तान के economic status, inflation आपके सामने. So be careful when you write medications to your patients. So again, these are SGLT2 inhibitors and GLP-1 analogs and their trials. And most trials with SGLT2 inhibitor and GLP-1 analog have shown reduction in MACE, major adverse cardiac event. And then the heart failure hospitalization is also reduced with SGLT2 inhibitors. And then we see renal benefit is seen with both SGLT2 inhibitors and GLP-1 analogs. So as you manage diabetes, lifestyle is the word go. You have to do lifestyle. Lifestyle पे तो बात करनी है. और lifestyle पे से बात नहीं करनी. मरीज से आप पूछे क्या खाया सुबह, डॉक्टर साहब परहेज, excellent. कोई खाया क्या है तो बताएं. तो डॉक्टर साहब 2 पराठे खाए थे मक्खन के साथ और साथ में देसी घी. I mean, we need to ask what they are actually taking. So again, the guidelines, the recent guidelines have completely changed. From 2018-19 guidelines, focus of the guidelines are now shifting. What they say is, somebody who is diabetic, newly diagnosed diabetic, who has atherosclerotic cardiovascular disease, or he is at high or very high risk of cardiovascular disease, you start not with metformin but SGLT2 inhibitor or GLP-1 analog. 60 years say metformin was the first line medication. First time European Society of Cardiology displaced metformin from first line and said in heart disease or high or very high risk of heart disease, start SGLT2 inhibitor or GLP-1 analog. This is the ADA guideline. They always used to say metformin first line hai, फिर second line आप खुद ही choose करें according to parameters. Then they changed. They said no, if you have atherosclerotic cardiovascular disease or high risk of cardiovascular disease, then your second line medication after metformin should be either SGLT2 inhibitor or GLP-1 analog. पहले क्या होता था? Metformin, DPP4 inhibitors, sulfonylureas. Now things are changing. Metformin, SGLT2 inhibitor and GLP-1 analog. And remember, the cost difference between SGLT2 inhibitor and GLP-1 analog is tremendous. Again, the focus, the target in diabetes management, HbA1c था 2009 में, 2015 में HbA1c, and now it's all about cardiorenal events. See, the shift has changed. It's not only about treating number. मैं बेगम को गिफ्ट ला के भी दूं, उसको पसंद भी नहीं आए, तो फायदा हुआ कोई? No. We have to manage in a way that affects patients' life, that makes patients' life better. Again, SGLT2 inhibitor promotes weight loss, reduces blood pressure, no hypoglycemia, and all these features, they help heart. I mean, hypoglycemia can trigger heart events. Weight gain can cause more cardiovascular disease. Blood pressure reduction helps cardiovascular disease again. So again, these features of SGLT2 inhibitors, they favor to reduce cardiovascular disease. Some quick slides to tell about the benefits of SGLT2 inhibitors and GLP-1 analogs. Time to first MACE, most of the studies for SGLT2 inhibitors showed that time to first MACE reduces, first cardiac event reduces with SGLT2 inhibitors. Again, time to first heart failure hospitalization significantly reduces with SGLT2 inhibitors, the studies have shown. GLP-1 analog, again, injectable agent, once daily to once weekly, very costly, 15 से 17,000 रुपए महीने की cost है. Again, the time to first MACE with most of the studies done with GLP-1 analog shows improvement. All-cause mortality reduces. So what is the current diabetes management then? Lifestyle has to be there. Metformin has been the gold standard medication. So does metformin affect cardiovascular morbidity and mortality? Studies have not shown clear-cut evidence. One, in 2017, a meta-analysis did not confirm to this. In 2019, the meta-analysis said metformin reduces cardiovascular mortality, all-cause mortality in CV events and coronary artery disease patients with diabetes. This is a recent 2021 meta-analysis which shows metformin is significantly associated with lower risk of MACE. So even after 60 years, metformin is number one. Probably we still cannot remove metformin from number one. But what has to be the number two and number three treatment is a debate. But remember, times have changed. Diabetes is a progressive disease. है ना, beta cells are dying every year 4 to 8%. आज मैंने A1C control कर लिया, 6 महीने बाद A1C फिर ऊपर चला जाएगा. What traditional diabetes management is, जैसे ही HbA1c ऊपर जाएगा, we will add a डाकू आने के बाद हम घर का दरवाजा लॉक नहीं करते हैं, पहले लॉक करते हैं. We don't need to wait. Sorry, मैं तो समझा टाइम खत्म होने लगा है. Thank you. So right in time, हाँ, मेरा टाइम अभी तो नहीं स्टार्ट हुआ, ठीक है. Okay, just 2 more minutes, right? So what happens is we wait for the HbA1c to go up and then add a medication. I mean, that's a failed approach. The new approach is start from a combination therapy, preempt, don't allow the HbA1c to go up. So modern science says start with a combination therapy. And this is the verified trial which combined DPP4 inhibitor and metformin. और अगले स्टेप पे उन्होंने सिर्फ metformin दिया और बाद में DPP4 inhibitor ऐड किया. Treatment failure was lesser with the combination therapy starting first up. So remember, in diabetes you need to probably start with the combination therapy. And remember the legacy effect. The better control of diabetes initially, your patient will continue to get benefit years down the road. Again, so the new approach, that is, the world is moving to from a glucocentric only to a glucocentric cardiocentric approach and a combination therapy to start with. So metformin, of course, there, and then SGLT2 inhibitors in GLP-1 analog where there is high risk or very high risk for cardiovascular disease. So mostly in the world today, it's metformin and SGLT2 inhibitor, which is coming up as the first line medication in diabetics. And this is where I want to focus. Start with a dual agent, start with an agent that protects heart right from the start, and control diabetes as well, because if you don't control diabetes, you have done nothing actually. So again, there are many other things. My time is just finished, it's the last minute. Weight management, exercise, diet, adequate sleep. How many of you sleep 7 hours every day? How many of you sleep 7 hours every day? मैं तो हाथ नीचे कर लेता हूँ पहले ही, ठीक. कल सोया था 7 घंटे, ठीक है? Yes. Hardly any hands, sir. Thank you. So you see 7 hours of sleep every day. Studies have time and again shown good sleep reduces cardiovascular disease, helps diabetes, and no smoking. In busy clinics, sometimes you are more engaged with medications only rather than these many other things. That is actually the cardiocentric approach to manage diabetes. So again, in diabetes, it is mandatory that cardiovascular protection is accompanied by an early intensive management of hyperglycemia, and to harmonize the gluco and cardiocentric approach, and an early combination to treat diabetes. So the whole point, my dear colleagues, is not only to treat the numbers. The whole concept is to reduce those cardiovascular complications that becomes the big reason for morbidity and mortality. Thank you very much.